بيستخدموك يعني.
لا تحت امرك.
هيقول لنا على هيجيب لنا سلايد برزنتيشن. اتفضل يا استاذ.
Okay. Thank you, Mr. Chair, for this presentation, and thanks for the kind presentation. So last month, Kidney International has reviewed some of the pioneer investigators and the nephrology leaders in the field, remote George Leach and others, and asked them, what is the most distressing and embarrassing aspect in nephrology practice? And the answer was, collectively, the lack of randomized control trial. We lie here at the bottom. Among 12 medical disciplines, we are the least to conduct randomized control trials. But also, we rank first in the negative trials, so that we have never succeeded in trials, which is really embarrassing. And again, the issue I'll be addressing today is cardiovascular disease from randomized control trials. And one of the persistent exclusion criteria that have persistently been followed is the exclusion of patients with chronic kidney disease, so that we have insufficient data to make generalizations. Well, again, if you compare the amount of hemodialysis population with underlying heart disease to the general population, and this is data from US, you will find they represent a minute population, but with completely different epidemiological data and completely different presentation. We didn't understand what was really happening, so that we called those predisposing factors as reverse epidemiology, which is basically a polite way to say that we do not know what's really happening anyway. And then if you look at the active interventions that have been proven in a randomized control trial to intervene with the progression of heart disease and major adverse cardiac events, you will find just a handful of studies, and most of them concluded negatively. You are aware of the statin failure in the progression of major adverse cardiovascular events, chronic kidney disease. The anemia correction had suggested even cervical paradox and disadvantage when used excessive ESA, predisposing to strokes, vascular access thrombose, and hypertension, and enhanced this with the increased use. And also the trials to halt the progression of CKD MDD failed to show a real survival benefit. And when we come to the intervention regarding the aspects of nephrology and dialysis, we find a marginal, a very minute marginal effect of those interventions. And this is the evidence from randomized control trials. So again, we nephrologists have a misinterpretation of those trials. For example, I will start with the ESA issue. We have concluded that excessive use can lead to enhanced mortality if you achieve higher hemoglobin targets. And so the current practice in UK and US have been using less ASA and more iron supplementation, ending in rising levels of ferritin. So that ferritin was on the decline for the last 2 to 5 years. Parallel with excessive blood transfusion to avoid excessive ESA use. And the impact and the outcome. A recent DOPS data study, which is one of the best studies in the nephrology field nowadays, and the largest at all in the history of nephrology, suggested that there is increased mortality, all-cause mortality, with excessive use of iron. And this was really significant at the point of more than 300 milligrams per month, and reached a clear separation if you exceed 400 milligrams per month of iron. And then in the regression analysis, called DOPS, are very famous for the multivariate analysis, they found that the cardiovascular-related mortality started at patients using iron more than 300 milligrams per month. So that we opted from less use of ACE to excessive use of iron, which would end at the end of the day to increase mortality. And you are all aware of the oxidative stress problems and such kind of things. So that, again, after multivariable analysis of the factors that could really be intervening, because this is an observational trial with the enhanced mortality, what we have found that the excessive iron use ended in excessive mortality, all-cause mortality and cardiovascular mortality. Another example, but on the other hand of the spectrum, if you look at one of the very much underestimated factors that we follow our patients with, in patients with chronic kidney disease, MBD, we are all underestimating the value of alkaline phosphatase in order to predict all-cause and cardiovascular mortality, despite the fact that it's more accurate than PTH, calcium, phosphorus, and more accurate than them all collected, and more accurate than them in all our patient population, in CKD, in dialysis, and even after transplantation. Alkaline phosphatase is a better predictor of all-cause cardiovascular mortality in all those groups. Despite that, we are neglecting this factor. One study found that alkaline phosphatase can predict hemodynamic bone disease better than low PTH level, and this was correlated even with bone marrow biopsy. So its performance even in the bone disease is much better. So that, again, we have now come to a new understanding of why the dialysis in its own have ill effects on our patients. And we are now appreciating very much the effort of McIntyre and his colleagues to understand what happens really in the dark side of dialysis, which is recurrent circulatory stress. And what happens is, you expose your patient to excessive fluid removal, to repetitive intradialytic hypotension, and then they have ischemia in the brain, in the gut, in the kidney, in the retina, and even in the vascular axis. And this would lead to translocation of bacteria and the progression of inflammatory syndromes and enhanced cardiovascular mortality and all-cause mortality. And this stress with subsequent ischemia and reperfusion injury could really present the correlation between the cardiovascular and non-cardiovascular disease, both in brain, guts, and the kidney. So that it's a ticking bomb, what we do to our patients in dialysis practice. This man, McIntyre again, he followed the patients with echocardiography serially every 13 minutes during hemodialysis sessions for 1 year and looked for the structural changes that become fixed by the end of the year. This one was for the ejection fraction and the other one was for the shortening fraction. And what he found that patients exposed to excessive intradialytic hypotension and excessive ultrafiltrate removal were predisposed to ischemia by the end of the year. And he also followed the patients by SPECT imaging and used the troponin as a biomarker to follow the patient and the cardiovascular progression. And those results were really again replicated by Noel, who used cardiac magnetic resonance to see the relation between intradialytic weight gain and intradialytic hypotension. And another subgroup post-hoc analysis from the HEMO study, the famous study, found that we are exposing our dialysis patients to a very fast, a very short, but a very aggressive and furious mode of treatment. And what the man basically found out, you have an increased risk of mortality when ultrafiltration rates exceed 10 milligrams, 10 milliliters per kg, if the patient had underlying cardiovascular disease, and this line would be clearly separated if you use more than 13 milligrams for all-cause mortality, meaning that if you are dialyzing your patient, exposing them to excessive ultrafiltration more than 13 milligrams per kg, no matter what he has underlying cardiovascular disease or not, he's exposed to enhanced mortality. And this will apply to the patients with underlying cardiac disease if you have excessive removal of 10 ml per kg better. And those data were again replicated in the DOPS trial, which found this correlation closely present for more than 10 milligram removal of ultrafluid rate. And again, they correlated that to the treatment time, because the data was conflicting. Japan had the best survival, there were European Union in the middle, and America were the worst. So that they adjusted the data, not only for the ultrafiltration rate, but also for the treatment time. Despite that, the effect of excessive ultrafiltration persisted through all categories. So that, again, we now know that we are exposing patients to fast and furious treatment that can kill them by the end of the day. And if we look at the mortality pattern so that we can analyze what we can do to those patients in order to offer them benefits, we find the same data from DOF study suggesting that the first year survival is very poor in our dialysis patients. We are losing a huge percentage of them, and the main causes of death are cardiovascular disease, infection, and vascular access problems. Well, again, 75 of our patients start dialysis with left ventricular hypertrophy, but 90% of them who will experience death will be due to sudden cardiac death, volume overload, or arrhythmia, long QT web syndromes. And again, 80% of the total population of the dialysis patients are starting, at least in America, and this DOF population, we're starting dialysis with central venous catheter. But the most important aspect that should be regarded here in this context is that about 1/3 of those population have opted to stop dialysis and withdraw from dialysis and die. So that you can at least spare those 1/3 of patients and offer them conservative management instead of exposing them to those extensive and aggressive treatments, especially if they are elderly patients with frailty syndrome and high index of comorbidities. Well, again, those data will be replicated again from the US this time. And they found that you lose 10% of your patients in the first 2 weeks, and then in the first 4 months, you lose 45% of your patients, and then in the first year, if your patient is less than 60 years, you will lose 20% of them. And this ratio is reserved. If your patient is 80 years, that at the first year, you lose 80% of them. And if you look at the comorbidity, you will find an average 12 hospitalization per year for a patient who's taking an average 19 pills per day, which is a huge burden of treatment with a huge cost. So that's the pattern that we have now for mortality. Heightened mortality in the first year, especially in the first 4 months, especially in the first 2 weeks, especially, as I will allude to later, in the first day of the week, the long interdialytic gap, and then in the evening shift. So that we are offering them basically unphysiological treatment. That how did we work with that? First, we analyzed the data coming from the patient mortality of long interdialytic gap. And we found that all-cause mortality and cardiac disease were the leading causes of this enhanced mortality in those patients who are dialyzed 3 times per week. And this data was published in the New England Journal, and then again, was reduplicated from multiple observational studies. So that again, if you analyze the cause of cardiovascular death, you will find them that were due to congestive heart failure and arrhythmias. So that a problem of volume overload and inflammation. And the most important aspect is that what we did as an intervention to decrease mortality ended by enhancing mortality. Because we had patients with hyperkalemia, and we offered them low potassium packets, and there was a linear correlation with potassium packets less than 2 millicuries per liter. But also, we were concerned with the CKD MBD. We tried to lower the calcium load, and I heard the discussion today about lowering the calcium in dialysis. And what we did basically was we offered the patient low calcium and low dialysis and low potassium. They had more and more hypotension, and we predisposed to long QT wave and ventricular arrhythmia and sudden death. That's what we had. So that again, if you analyze this phenomena, we are concerned about the vascular calcification, which is an arterial thing. There's no question about that. We are concerned about the hyperkalemia, which ends in arrhythmia. There's no question about that. And we are concerned about the volume overload and the toxin burden of the patient, which ends in LVH, ending in cardiovascular death. But our interventions completely failed the patient in the other direction. And if you analyze the data related to sudden cardiac death, which accounts for 25% of the deaths in our dialysis patients, we found that they were mainly due to electrolyte imbalance, long QT wave dispersion, QT wave variability, which are mainly related to calcium, sodium, phosphorus, and potassium. And even more else, they were a mirror image of what happens to those patients. Sudden cardiac death was highest in the first 12 hours after dialysis, and then again at the third day of the long interdialytic period. So that patients are accumulating fluid, you have excessive ultrafiltration, and you modulate the dialysate, they undergo their way to sudden cardiac death. So what we did about that, this again to emphasize the importance of sudden cardiac death. The interventions that we have tried, some of them have succeeded within limits. The evidence we find will be at best, because they are mainly derived from observational trials. The Betablockers succeeded to decrease the rate of sudden cardiac death. The aldosterone blockers, of course, will conserve hyperkalemia. And there's an ongoing mass control trial to see what ICDs could be offering for the patient as a primary prevention for sudden cardiac death. But again, if you are using a dialyzable beta blocker, your patient is again at risk of sudden cardiac death. And this is recent data that show that patients taking beta blockers, which are dialyzable, are again at higher risk of cardiovascular risk. And then it was found that the non-dialyzable group are safer to use in the dialysis patient. So that be aware of which beta blocker you should be using in your dialysis patients. And this is an old debate that has been consumed many times regarding which is more harmful for the patient. Is it about volume overload or is it about toxin accumulation? And the answer is easy, of course. It's a combination of them. But the management would differ. Because if this phenomenon that we have, the long interdialytic period, is related to excessive accumulation of fluid, you can offer the patient other options, like dialytic therapy if it still has residual kidney function, or whatever kidney device, maybe if you can afford that. But if the issue is related to aggressive removal, you will go for increasing frequency. So let's see what happened when we tried increasing frequency of dialysis to improve mortality. Intensive daily dialysis, whether in center or at home, did not offer a clear survival advantage for our patients. First, randomized control trials suggested some benefit, and then observational trials will come in conflict with those results. And why is that? We all know that good intentions will not prevent bad outcomes. What happened is that when you increase the frequency of daily dialysis, you are exposing your patient more and more to the loss of residual kidney function. There's no question about that. But the main cause of morbidity and mortality was the increased vascular access problems. So that you are dialyzing your patient every day, that there is more chance that you have a vascular access problem. That's why the advantage from frequent dialysis disappeared in front of those kind of complications. Well, again, the monitoring of the blood volume, the monitoring of the blood volume is a very complex and heterogeneous process. It requires multiple modalities to detect what is going on. Let's show the data regarding the potassium, so that if even the transient, the gradient between the patient and the dialysate is asymptomatic, you can follow this plan that was suggested by Michel Joudon, who was he is offering this data. And then again, if you are offering your patient low calcium dialysate, please be aware of that he is more exposed to intradialytic hypotension, especially if you are using low potassium dialysate. So that this is a bad combination. And once again, this data from DOPS study has suggested that the modified interventions that could decrease the mortality rate were increasing treatment time, improving the solute removal, the avoidance of excessive removal of ultra fluid accumulating, and avoiding the low dialysis and potassium. Just in 1 minute, what is going on now is trying to address another aspect. Okay, ischemia will be going no matter what you do. Our patients will be always exposed to ischemia diffusion injury. So that we will try to modify this phenomenon. So that first thing, and again from McIntyre, and this one succeeded by the way, was directed towards inducing remote ischemic preconditioning, meaning that he induces ischemia at a certain leg or certain arm using a simple cup device. It's a very simple technique without cost. And again, it showed some benefit. Still pilot trials, but it's very, very promising. And again, McIntyre tried to cool the dialysate, and he published the data of his first randomized control trial that showed that cool dialysate, less than half degree of the patient temperature, induced a preservation at least of the diastolic function before those patients for 1 year. It didn't improve the systolic function, but it's only 1 year. So that is promising too. And it doesn't cost anything, does it? And also, for the brain change that he was following by MRI, that we were addressing about the repetitive ischemia, he found that cooling of dialysis would prevent from the progression of the subcortical wide motor ischemia, which ends in depression and dementia by the end of the day. So that this is a very effective technique, and a very simple one. Well, again, another trials, and this is the last slide, have been trying to address the nature of the hereditary toxins, because all that slides we were talking about the body. Again, we now understand that we have small water-soluble protein now, and little molecules, and we are now offering dietary interventions to decrease the generation of uremic toxins in the gut. And there are many products that are coming. AST has been used in Japan for years. It has improved promising results. And this one will be interfering with sodium, calcium, phosphorus absorption from the gut. So that your patient may take high salt, which is a very technical, demanding problem when you inhibit your patient from salt taking. The patient will be taking salt, and you will give him the exchanger, something like arizine or something like that, that will be working in the gut to eliminate the absorption of sodium from the food. And again, treatment time, increasing treatment time only by 13 minutes for the same regimen will improve outcomes in terms of blood pressure, hemoglobin, phosphorus, potassium, but also, and more important, the all-cause and cardiovascular disease. And don't forget that this patient is a multi-complex disease that we have to offer in the multidimensional care and things.
بشكرك فعلا صدام. I enjoyed very much your talk. ماشي مع الترند